Seated first rib manipulation. This technique targets the first rib, R1, and is performed with the patient seated. Stand behind the patient and elevate your contralateral leg onto the treatment table. Gently place the patient's ipsilateral arm across your raised thigh. Instruct the patient to rest their opposite arm comfortably on their own thigh. Using your support hand, make contact with the temporal region on the contralateral side of the patient's head. Then palpate the first rib just posterior to the clavicle. Form a pincer grip with your thumb and index finger over R1. Laterally shift the patient's upper body towards your elevated leg to preload soft tissues and identify resistance. Once you encounter soft tissue tension, engage the barrier by pressing from superior-inferior with your contact hand. Simultaneously, use your support hand to laterally flex the patient's head towards the involved side, thereby increasing the tension through a controlled counterforce. Instruct the patient to take a deep breath in and then exhale fully. As they exhale, apply a focused manipulation by thrusting SI to LM with the rib contact hand while guiding the head with the support hand, creating a diagonal vector of force towards the axilla. Key points. The first rib is best palpated just behind the clavicle. Patient breathing and tensioning the skin are crucial for effective force transfer and precision. Adjust the patient's position near the back of the bench to minimize therapist overreaching. Always gain consent before establishing arm contact. Ipsilateral prone first rib manipulation. This prone variation is also designed to adjust R1. Position yourself beside the treatment table in an asymmetrical stance. Use your ipsilateral hand, e.g., right hand on the right side, to contact the rib with a plexiform, locking the elbow and slightly rotating the shoulder inward. Your contralateral hand contacts the patient's head at the temporal bone just above the ear. Ask the patient to take a breath in and exhale. Midway through exhalation, compress posterior to anterior through the contact hand and simultaneously rotate the head toward the contact side using the head hand. Your upper extremities should be well aligned. The contact arm must remain parallel to the table surface, avoiding any upward lift that might cause facial discomfort from the face hole. Once the tissue resistance is engaged, deliver a manipulation combining rib compression with cervical spine rotation. Key points. Keep your guiding arm level with the table. Excessive elevation can cause unwanted pressure on the patient's face. Time your thrust precisely at the end of exhalation. Use body weight, not arm strength, to generate the adjustment. Seated rib 1 manipulation. Using arm leverage. With the patient seated, have them place the palm of their ipsilateral hand behind their neck. Stand behind the patient in an asymmetrical stance and secure a towel against the thoracic spine to anchor your contact. Use your hands to clasp around the olecranon, interlocking your fingers. Ensure the patient is upright with a neutral head position and that their opposite arm does not compress their neck. Request a full inhale and exhale. As exhalation completes, you'll feel the end range barrier. Thrust antero-posteriorly through the arms into the rib cage. The angle can be altered to suit individual anatomical variation. Key points. Make sure the patient maintains an upright posture and a neutral cervical spine. Avoid compressing the neck with the opposite arm. A towel can help block scapular motion and isolate the AC joint if desired. Contraindications include instability of the shoulder or elbow pathology. Effective for improving mobility in adhesive capsulitis. Seated humeral head manipulation. With the patient either seated or supine, position yourself facing the side to be manipulated. Support the patient's extended arm at the elbow, cubital fossa over your shoulder. Interlink your fingers around the anterior aspect of the proximal humerus, with your palms cupping the medial and lateral borders of the upper arm. Ask the patient to breathe in deeply and then exhale. As the breath is released, engage the barrier by gently compressing the humeral head and deliver a controlled inferior glide. Key points. This technique requires minimal force. Avoid use on patients with glenohumeral instability. Elbow flexion is acceptable if preferred. You may use a towel to reduce pressure on the patient's shoulder. Make sure your hands span the humeral head, not directly over the AC joint. Seated acromioclavicular AC joint manipulation. The patient is seated. Stand behind them, placing a towel along their thoracic spinous processes to ensure a firm, stabilizing contact. Place your anterior hand over the AC joint, resting the second metacarpal over the mid-clavicle. Your posterior hand reinforces the contact by bracing across the patient's chest. Instruct the patient to take a deep breath in and then exhale. At the end of the exhalation, engage the barrier and apply a thrust directed in a posterior-superior direction, focusing on AC joint displacement. Key points. Avoid this technique in patients with a history of AC ligament reconstruction. Be cautious with those who have experienced clavicle fractures. Supine sternoclavicular SC joint manipulation. The patient lies supine. Stand to the side of the plinth corresponding to the SC joint to be treated.